Afternoon, everyone. Thanks for joining the SAPRIN Population Science webinar. And we're just going to wait another minute or two before we start. And so just to give people, because we see some people still coming in through the lobby. Thanks. Thanks, everyone. So it's just after 3, but I think that we can start, and it gives me great pleasure to welcome Professor Lucia D'Ambrosio, who is a Deputy Director in the Department of Global Public Health at the Center for Global Development at the University of Aberdeen, and with an affiliation to the University of the Witwatersrand. She's a social scientist committed to interdisciplinary and intersectoral working with interest in social, political, and commercial determinants of health, inequalities, participatory theory and method, health policy and systems, social policy, knowledge transfer, and health data and surveillance, which includes verbal autopsy, circumstances of mortality, and social audit. She has worked internationally for over 20 years with universities, research agencies and networks, civil society groups, social enterprises, United Nations organizations, and in government. Her research is supported by research councils and philanthropic organizations, applying social science approaches to strengthening public health policy and practice and integrating mortality surveillance into health system governance and applying learning, deliberative and conscientious consensus methods. She co-founded the WHO Collaborating Center for Verbal Autopsies at the University of the Witwatersrand and develops work streams on the ethical, social, and computational divisions of mortality data. She co-founded and serves as Deputy Director for the Center for Global Development at the University of Aberdeen and contributes to postgraduate curriculum design, supervision, and global health policy advisory groups. And the topic of discussion for today's talk is the ethics of verbal autopsy towards trauma-informed practices. Thanks, Lucia, very much for availing yourself to do this talk. And this is certainly an important and core part of what we do at SAPRIN. And so we're very eager to hear your thoughts and insights. Thanks so much.
Andre, thank you very much, and thank you for the invitation. And good afternoon, everybody. Thanks to SAPRIN for hosting this webinar and for inviting me to speak. As Andre mentioned, my name is Lucia D'Ambrosio, and I'm based at the University of Aberdeen, but also the University of the Witwatersrand, where I've spent the majority of my career, actually. And as we heard there, today I'm going to talk about the ethics of verbal autopsy, and in particular, how we might move towards trauma-informed practice. There's a question mark in this title, and that's deliberate. This is a work in progress, and I would really value your thinking and discussion around it. I'll talk probably for about 30 to 40 minutes, and hopefully there'll be some good time for discussion. So by way of overview, I'll start with the rationale and aims for an empirical study looking at the ethics of verbal autopsy. So I'll give some background on why that matters at the moment. Then I'll outline our methodology. This was a rapid qualitative study across 3 SAPRIN sites. The heart of the talk is really our implementation experiences, what people are actually doing, and what they told us about their VA work. And that leads into a draft practice framework, which is the main sort of contribution of this piece. And I'll finish with some next steps and future directions. Now, the photograph in this slide is not from South Africa, obviously. It's a verbal autopsy that I took part in a province called Pandeglang in Indonesia in 2004. And I like this photograph because it shows the reality of verbal autopsy. As I'm sure the majority of this audience is perfectly aware, these are not closed clinical confidential consultations. As this image suggests, people come and go, contribute information at different times. And this is what VA can be like in practice. It's just one of the emotional and interpersonal dynamics that field workers face and navigate. So for anybody that's not familiar with verbal autopsy, as I said, I'm sure most in the room are, but for those who might not be, when a person dies outside a health facility or without medical certification, the cause of death is simply unknown. VA is the method we use to address that. It's a structured interview with a final caregiver, usually a close relatives, about the signs, symptoms, and circumstances of the period before death. Those responses are then analysed increasingly by computer algorithms to arrive at probable medical causes. And when we do that in sufficient numbers, we can see burden of disease in otherwise unregistered populations. And that's what matters so much. These are populations that are otherwise underrepresented or entirely visible in official mortality data. So the public health benefit is significant, but so are the obligations and created by that encounter. And it's that encounter, where that data comes from, that this talk focuses on. I want to dwell a little bit on the scale of this need. This is a very old slide and it's from the WHO, which I've attempted to update somewhat for this talk. In 2015, WHO data suggested that 1 in 3 to 1 in 4 deaths worldwide are not recorded in terms of medical cause. This astonishes me after 20 years in this space. And I've attempted to update this slightly, and from material in 2024, the WHO assert that about 8% only of reported deaths in low-income countries have a documented cause. The late Professor Peter Bias, who several of you may know, put it simply, verbal autopsy is the only real alternative in this context. And I think the field has responded, led in part by groups like SAPRIN and the South African Medical Research Council, with digital tools, automated coding, routine systems. These are making verbal autopsy feasible at scale increasingly. And it's transferring, it's moving out of health and demographic surveillance, out of research environments, and into routine systems of civil registration and vital statistics, into pandemic preparedness and mortality surveillance. And the scale, I think, brings into focus the ethical concerns and considerations. When you scale verbal autopsy, you multiply those human encounters, and every encounter then multiplies the emotional load carried by the people doing the work. This is also an old slide, and it's one from, and I hope honours the work of, in part at least, the late Professor Peter Bias. Peter did a back of the envelope calculation one afternoon that of those 37 million or so deaths annually that are not reported in terms of medical cause, one laptop, I think this slide's about 10 years old, running with automated verbal autopsy interpretation software, about 100 VAs a minute, using about 4 kilobytes per case. A single laptop running 24/7 with a very modest amount of storage could process those missing deaths with verbal autopsy. And the point I think Peter was trying to make in this slide is processing is no longer the rate limiting step. It's not the algorithm, it's the human work. It's the entering homes, asking difficult questions, holding people's distress during that encounter, and often carrying the consequences of that away afterwards. That is the substantive content and the ethical imperative running through this talk. All right. When you look at how the verbal autopsy field has progressed, there's quite a striking imbalance. On the one hand side, there's been extensive development in the computational cause of death algorithms, in tool standardization and validation, in mobile and automated verbal autopsy. As I've been alluding to, these have opened significant possibilities of scale. And also comparability across settings. Of course, critical for population mortality surveillance globally, regionally, nationally, and so on. This is a genuinely mature technical field. On the other hand side, and what is probably comparatively neglected, is the emotional toll on people involved, primarily respondents and interviewers, the moral distress and the vicarious trauma, the ethical reporting and data protection in verbal autopsy studies. And one point that we'll focus on today, how that burden is differentially distributed across teams and institutions, and how responsibility for that can be organized in a collective, in a cooperative way. So what we have is a mature technical field, but with an arguable technical, ethical blind spot. Now, to be fair, there's a decade of evidence on the ethics of verbal autopsy, and our work has we very much intend to draw this together, build on it, and extend that sort of reasonably modest handful of key pieces of scholarship in this area. And that scholarship does cover a lot of ground around cultural sensitivity, around the timing of interviews, mourning practices, reciprocity and relationships, around public health ethics and the concerns that come with scaling, around technology and the ethics there, around the emotional labor, the moral uncertainty and the safety, around clarity of consent and choice, and of course around protecting privacy and confidentiality. And I think the kind of common thread through all of this is that ethical practice is intrinsically and instrumentally important. It's not just a nice to have. It underpins trust, workforce resilience, data quality, and sustainability of this whole system. It's critical. So what I offer today is really built on this body of work. It's a product of that decade and not a departure from it. All right, so our objectives in this empirical study were to first examine the ethical and emotional challenges experienced across different implementation roles in VA teams. Second, to look at what's being done, practices in place that are used to support both respondents and implementers in routine programs. And third, as I was saying, to draw that together to start to build a trauma-informed practice framework that's grounded in that implementation practice, experience, and need. And that's really the idea that I'm delighted to have the opportunity to develop and discuss here. This work doesn't see trauma-informed practice as a set of interview behaviours. We came to see it as a distributed responsibility across the whole mortality surveillance system. I'll talk more about that as we go through. All right, in terms of the approach, briefly, we worked across 3 SAPRIN nodes with generous support, strategic guidance and oversight from SAPRIN. And they spanned rural, peri-urban and urban implementation contexts. We spoke with 13 VA implementers whose experience ranged from under a year to over 20. There were 9 women and 4 men. And crucially, this wasn't just interviewers. This included supervisors, coordinators, even public engagement staff. We used rapid qualitative methods. This is the real informed rapid quality approach. It's team-based, iterative, with structured summary matrices that are analysed collaboratively in step with data collection. It's an approach that was developed by Vindrola Padros and colleagues at UCL, University College London in the UK. It really came to the fore during COVID for producing qualitative findings in a short timeline, working with matrices, structured team reflection, and systematic comparison across roles and sites. So in the short time this team had together, it allowed us to develop a key analytical focus. We organised our analysis around a key variation, those implementation experiences, mandate, context, and support. And that'll frame, I hope, the findings I will present. So across the narratives we elicited with that approach, 4 key themes emerged. The first was on those challenges, those ethical and emotional challenges that exist across roles, as I've alluded to. Secondly, the how that is navigated by implementers, that complexity in real time. Third, how practice is supported and where improvements might be possible and valuable. And fourth, learning from implementation, grounding in practice. That's where our framework comes from. All right, so starting with the emotional terrain of the work, in implementers' own words, one person described going into these verbal autopsy interviews with bare hands, with families living in poverty who expect material help. And the interviewer arrives with a questionnaire and little more to give. Another described experiences as putting salt in their wounds, the discomfort of bringing a structured tool to a period of grief with little room for the person's mourning. One field worker from a rural and peri-urban site told us, "I feel guilty. I'm the only one who's asking the questions that make them cry." And another from a rural site, listening to a mother crying for her child, you get back home and it comes back. The emotional work here is not incidental. It's part of how verbal autopsy is made possible. And these are very real and cross-verified experiences. And these complexities have to be navigated, as I said, in real time and often with little or no script. Implementers told us there is no one size fits all. There's a constant balancing of the demands of the procedure with simple human empathy, asking sensitive questions about bodies, bodily fluids, mental health, HIV, violence, and the circumstances of death, trying to maintain privacy in crowded households and close-knit communities, managing genuine safety concerns, particularly and repeatedly for women field workers, and fielding that recurring question from families, what have you brought us? As one urban field worker said, we're employed to administer a questionnaire, but we do much more on a human level. And that's, I think, what's meant by moral uncertainty, seeing a need clearly, but perhaps lacking the full mandate, the range of resources to completely respond to it. And the tolls of this were cumulative and only partly visible. The emotional labour was reported as largely unrecognised, with distress that is normalised and coping that is improvised through things like peer talk, through prayer, through family, and through crying alone after interviews, through acceptance and through emotional distancing, and of course, all of the above in different configurations. And this manifests reportedly in the home and the body. GI complaints, chest pains, insomnia, health anxiety, Sometimes the very symptoms that implementers had been hearing about in the field were projected onto themselves and their own families. We were interviewing people about their work, and for some of them, this was the first time anyone had asked how the work was affecting them. This burden varied by role, and I think this is something of a novel finding. Frontline implementers reported facing direct and repeated exposure to bereaved households, of course, it's self-evident, and that grief had to be suppressed during interviews, absorbed, then taken home. Guilt at being the one to make them cry, as I've said, but often with no ability for follow-up. The demands to hold composure in the face of child deaths, of suicides and violence. But supervisors and coordinators carried something we came to call a sort of a layered double exposure. They carried internalized effects, oftentimes of their own years on the front line. And then on top of that, ongoing exposure to managing distressed teams, allocating difficult cases, absorbing their colleagues' accounts, and responding to express needs. In other words, moving through team roles often transformed the exposure, didn't reduce it. It was a compounding form of exposure. So I think the point is that this unevenness was somewhat structural, and it relates to mandate, responsibility, and layers of it. This goes beyond an awareness of the need for sensitivity and is a wider theme I'll return to. The interviews revealed that across sites, support exists, real provisions exist, field protocols, panic buttons, structured debriefing, but they're concentrated in the better resource sites. Several are respondent facing rather than support for staff themselves, and frontline field workers oftentimes don't receive them. What would protect the workforce, in addition, for example, paired working, location monitoring, recognition and certification, trauma-specific training, were things some respondents suggested as useful additional provisions. And again, supervisors and coordinators highlighted an interesting asymmetry. They articulated support as something they provide downward to their teams and recommend upward institutionally, such as and including well-being interventions, regular debriefs, in-house and ad hoc counselling, and other forms of training. But curiously, their own well-being and receipt of these types of support seemed relatively thin, self-organized, or even unspoken. And we thought this was a pertinent finding. Supervisors described support from the provider side, but their own needs were often unspoken and unmet. And I think this was a point that helped us focus on leverage points, where the authority exists to resource and support teams, to schedulize it and to formalize it, that sits above the front line, perhaps, with supervisors, coordinators, and of course with institutions. And that took us to questions of responsibility. Who's actually able to act on this? That really directed our analysis. One site in particular showed us what strong and responsive support can look like. It was an agile, notable, and interesting response. They had introduced biannual social worker referral for all field staff, regardless of reports of need. Monthly structured debriefing sessions and standing open door access to supervisors. And this was built in direct, swift response to a period of acute distress amongst field workers. So that was institutional learning in action. And participants linked this to real things, reduced absenteeism, improved morale, in their words, consistency of data quality. Although, to be transparent about this, frontline staff also told us that those provisions didn't always reach them. And I should flag, these were perceived mechanisms. These weren't measured outcomes. Nevertheless, this theme came up consistently and independently across roles and across sites. It was the implementers' own causal reasoning about their practice. They told us things like rushed pacing limits disclosure and limits narrative depth. Suppressed distress kind of constrains the interview and narrows rapport. And cumulative exhaustion was linked, in their words, to increased data errors. Again, being completely clear about what this study is and what it isn't, we elicited experience. We did not measure data quality. So this is a perceived mechanism, and it might be something worth testing, but for us, it wasn't a measured outcome. All right, so coming to the framework. Our participants gave us rich, concrete recommendations, and they clustered around responsibility, collegiality, and wider trauma-informed principles. But as we started to develop these, it became apparent that a flat list of recommendations wasn't enough, and especially given that role differentiation, responsibility, and mandate to act that we had observed. Because those who can see what is needed are not always those who are empowered to deliver it. And we worry that, a long list of recommendations might reproduce the very gap that we'd come across. So we built the framework really around three things: around responsibility, around mandate, and around voice, around the institution, the team, and the interviewer. Those hold the mandate to act, whereas the respondent and the community, they hold voice. They're the ones who must be answered to. And of course, with some degree of crossover of voice and need from interviewers and supervisors themselves. So we wanted to develop a practice framework that sort of transcends a need to be sensitive into a slightly sharper question about who must do what so that sensitivity is possible and possible routinely. So we layered this idea of responsibility, mandate, onto trauma-informed frameworks and concepts, which I will share here. So at the top, this is a standard definition of trauma-informed practice, which applies also to trauma-informed research. It was developed initially by the US Substance Abuse Mental Health Services Administration. It's often called the 4Rs, a trauma-informed approach that realizes the widespread impact of trauma. It recognizes the signs and symptoms. It responds by integrating knowledge into practice and actively seeks to resist re-traumatization, to not inflict further harm through the very process that is meant to help. And then at the bottom are the 6 principles. These are the kind of normative trauma-informed principles that flow from that definition. So safety, trust and trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. And these came out, as I said, of the established trauma-informed literature from a range of areas. And these 6 principles are the ones we've built our framework around. We applied and established recognized models and considered quite concretely what it means for verbal autopsy. And as I said, we mapped them onto those ideas of responsibility across the surveillance system. So this is our draft framework, those same 6 trauma-informed principles built into verbal autopsy and into those implementation experiences and needs. So at the centre here, of course, sits the bereaved respondent, surrounded by the verbal autopsy implementer, an implementation team, and around them, the 6 trauma-informed principles, safety and trust, in the context of verbal autopsy, physical and psychological, trust and transparency, the honest framing of what verbal autopsy is, clear and informed consent, of course, the peer support, as we heard so much about, both the existence of and the need for structured debriefing and support networks, collaboration and mutuality, and formal and informal channels for shared design and the sharing of fieldwork experiences. Empowerment, voice, and choice, recognizing that emotional labor, expertise, and competency. And for respondents, the ability to narrate freely. And finally, cultural, historical, and gender awareness, particularly that is adaptive and specifically that is gender aware. And we mapped these letters that are mapping of which actors are implicated in each principle across the institution, the team, the interviewer, the respondent, and the community. And I think one of the key features here is contribution. The mandate to act sort of runs inward, from institution to team to interviewer, with voice, feedback, and legitimacy running back outward, from supervisors, teams, interviewers, respondents, and communities. So these responsibility sort of flows towards the encounter and voice flows back from it. We've had a go at populating this framework. There's far too much information on this slide to absorb, but nevertheless, the key point is that every principle needs an institutional owner. Looking across the rows for each of the trauma-informed principle, for all 6 principles, an institutional mandate is implicated. So safety needs resourcing that only institutions can provide. Trust needs a community engagement strategy set at a level that is above the individual interview, and so on, all the way down. Interviewer and team practices are essential. They are necessary, but they're not sufficient, is the assertion this framework makes. The enabling conditions sit at the institutional level. So 2 quick examples. On safety, the institution resources a field safe policy, panic buttons, and tracking. The team plans routes and uses paired working. The interviewer flags risks and follows protocols. Respondents choose safe, private places for interviews, and communities help nominate safe spaces and vouch for interviewers. You can see those 5 actors enacting that one principle, and similarly on trust and transparency. The institution sets the honest community engagement strategy. Team briefings enable consistent messaging. Interviewers explain purpose and the limits of the verbal autopsy process. Respondents can ask questions, decline, pause, and withdraw. And communities co-design the process and how it's practiced locally. So the point throughout is practical. Every principle needs an owner, a route for feedback, and a mandate to act. So fundamentally, this is a workforce issue. Taking that organisational approach, we realised repeated exposure to grief, trauma, unsafe environments, it's a psychosocial workplace hazard. And that means institutions owe a duty of care exactly as they do and would for physical safety. Compassion, fatigue, and burnout are, in effect, occupational injuries in this context. And the WHO Healthy workplace framework gave us a model for this. Psychosocial support, access to mental health, stress management, and peer networks. So this moves us from a language of individual resilience to a language of occupational health, recognizing emotional labor, protecting time for debriefing, providing referral routes and building peer support, designing gender-aware field safety. These are workforce issues, not only individual ones. All right, so next steps, I can probably see two. There may be more. First would probably be to test that well-being data quality link directly, potentially through comparative or longitudinal designs linking implementer well-being and institutional support to VA completeness, accuracy, and interview quality. That's the kind of hypothesis that emerged and I mentioned earlier. That is probably testable. Secondly, to apply and refine this trauma-informed verbal autopsy framework across VA in the context of health and demographic surveillance and in civil registration and vital statistics settings. And I guess the question here would be, does naming mandates actually shift accountability, support practices, and outcomes in routine implementation contexts? And again, this study elicited experience. It did not measure data quality. So that is a link that may be worth testing. It is not proven in any way here. All right, so overall, we hope that this small study has three core contributions. First of all, the emotional labor and burden in verbal autopsy are cumulative and they're uneven. Frontline and supervisory roles carry distinct exposure, including that double exposure among supervisors. Secondly, there are real occupational health implications in mortality surveillance and institutional responses required across the implementation system for that emotional labour, for burnout, for moral distress, and for vicarious trauma. And third, a practical framework, trauma-informed verbal autopsy with that explicitly specified accountability designed to be adopted proactively, flexibly, and reflexively at low and no cost, as one of the sites in the study had really begun to show anyway. All right, so in conclusion, routine mortality surveillance depends on relationships of trust and care. Verbal autopsies embody a basic tension. VA fills major global data gaps to understand burdens of mortality in an aggregate way in settings where many deaths never reach formal registration, but it does so by asking oftentimes grieving relatives to recount painful, sometimes stigmatized details and death. If we ask field workers and families to routinely support the investigation of these deaths, and in doing so, navigate grief and hardship for population health benefit, we owe them a system that supports their safety and well-being and respects them as they do so. So our trauma-informed verbal autopsy framework attempts to extend sensitive practice into multi-level and system-level responsibility with explicit acknowledgement of the complexity of emotional and ethical labour and skill required at all levels of the surveillance system. And I've included a quote from Bisani and Koch from 2017, that the political legitimacy and technical validity of global health estimates would be improved if estimation processes work from the bottom up. And that, in the end, I guess, is my case for taking the workforce so seriously. I'd like to end with acknowledgements to the co-investigators on the study across FITS RHI, across KEMRI, and of course at SAPRIN, to SAPRIN for the seminar and the opportunity to share these findings and the WHO Collaborating Centre for VA at WITS. Thank you very much.
Thanks, Lucia. That was very insightful and quite sobering as well. And we can open the room for questions. If there are any. I don't see any hands, but I'd like to start off, Lucia, and ask you about how we balance the need for accurate mortality data without re-traumatizing the respondent, and if you have some thoughts around that.
Thank you, Andre. I think that's the core tension, isn't it? That nexus is where SAPRIN really sits, and of course the nodes within the network and VA teams more broadly, and as I've said several times, extending now into civil registration and vital statistics systems. I think our data in this study show us that the answer is between us. Those differentiated roles, as I was explaining, really got us thinking about strategic entry points, responsibility, mandate, and power. And we came up with that kind of distributed accountability framework. So to directly answer your question, I think it's about understanding and listening to those practitioner experiences, which happens anyway. We surfaced a lot of experience and anecdotal evidence on this, but then thinking strategically, small p politically, about where the responsibility to enact those lies. Hence that framework with the distributed responsibility from institutions to teams to verbal autopsy interviewers. We did not in the study talk to respondents and communities, but it's next to self-evident that their experiences and needs, including emotional, are an important part of the discussion. And I guess we hope that framework encapsulates the entire horizon of the people who have vested interests in routine mortality surveillance. So I think listening and strategizing is the short answer.
Thanks. I think it's quite a difficult sort of dynamic to navigate, because on the one hand, we want the information because it helps inform and understand mortality and what we can do to change it. But then there's this tension between re-traumatizing, etc. And so I have to be honest, before we did the project, it hadn't also occurred to me, and this is my next question, about the field workers or the verbal autopsy interviewer, about the risk that they are taking in terms of the trauma they experience. And I think it's, I don't know, it's more a comment than a question, I guess, but that, we almost expect them just to get on with the job. And where it resonated for me was that as a junior doctor, it was that there was this, you don't realize the trauma that you're experiencing from working in the wards, and because there's this almost expectation and ethos that's been built that you actually just have to carry on with the job. There's no time to stop and reflect and to say, but someone has just died, or you've had a difficult call, and you actually do need to debrief from that. And so it reminded me a little bit about that we almost take for granted that the interviewer, field worker, just has to carry on with the job, but we do ask them to go into very difficult domestic situations that
Yes.
can often be very traumatizing.
Yes, yes. And I think that taken for grantedness is entirely reasonable. And a lot of the implementers that we talked to had deep commitments. As I was saying, some were just fresh verbal autopsy interviewers, less than a year's experience, to people with over 20 years. That speaks for itself. This is a deep commitment to the community and to understanding the population health profiles of the community. And I think because of that potential, I guess, vocational motivation, and I think we see it across various professions, don't we? There is something of an absorbing. I do think as we, become a bit more enlightened about mental health, and about trauma, there are ways to navigate and understand the extents and forms of it. And I would even further that surfacing and systematizing those experiences and translating them into different forms of accountability and responsibility from institutions to communities is potentially a way to resolve that trauma and to enact. I'm hesitating before I say care because this is about population health surveillance, but to support better data that is
Mm.
collected more ethically and with, with awareness of these complex issues. It is definitely a balancing act, as respondents themselves said, but nevertheless, I think that is the space. That is one of the key entry points to locate this work within.
Sure. No, I definitely think increased awareness will help contribute to, to producing a more mentally or addressing the mental health challenges within the workforce just globally. Neetha?
Hi everyone. Thanks very much for that excellent talk, which has taught me a lot. So I was wondering, you did mention next steps is moving towards the community and understanding that. And I was wondering what made the team not start with community context, because as I understand it, if we understand how death is perceived within a community context, we would be able to gather the cause fluidly. Because when I think in my own cultural, social context, when death occurs, there's so much of communication and discussions around why, how, when, what, and so an ethnographic approach may be useful to move us forward so that we all have the common goal of the why. For us it's researchers, but for the person affected, it would be understanding that the second point I make is, the purpose of death has a very deep cultural slash religious context, and the more we begin to unravel and understand that at the outset, we would able to get better data without people hiding it. Those are my thoughts about, I'm happy we in somebody going to the community, but what made us not start with that at the outset and having an ethnographic approach? Thanks.
Thank you, Dr. Etha. They're brilliant questions. So I think we didn't start at the community. The Dr. Alex Hinga's work. Alex is from Kemry, and he's done some really quite original work on um, the emotional and moral distress and uncertainty in VA teams. And a lot of his scholarship, which builds on that modest decade of work that I attempted to summarize earlier, um, tries to redress a bit of a balance. I think a lot of the scholarship already focuses on the community. I think a lot of DSSs do. Agincourt is the DSS I know best, and it does incredible work over long periods of time, working with the community just around the things you're describing, the meanings of death, the importance of community entry and understanding traditional governance systems, for example. So we felt that where there was something of a gap in the knowledge base was around the implementer experiences, what it was like to have that repeated exposure. The respondent, notwithstanding the traumatic effect of recounting a death, such a personal set of circumstances and outcome, of course, but the interviewers, they go through that process multiple times every day. So we thought it was worth starting there, but absolutely take your point to go further into that and towards your second point around meanings. I guess meanings of death have another side on the institutional, on the population health surveillance side as well. And as I said with Andre, you know, the answer is between us. We started to, just on the implementation side, really unravel that the more that those connections were made, the more that we did not think in silos, albeit institutionally, the more we could think about more holistic models, I guess, with those distributed forms of accountability, mandate, and responsibility. It implicitly acknowledges power. But your point is well taken. You know, those respondent and community aspects warrant investigation also. I would also like to make a quick point that for implementers and particularly for interviewers, the risks, of course, were not only psychological, they were also physical in many instances. So women interviewers in remote rural homesteads, for example, were often reported perceptions of quite serious risk. That are worthy of investigation. Dr. Neetha, I hope that answers your question.
Yes, thank you. I mean, we learn lessons all the time, and I think it's exciting to enter this territory from that perspective. Thank you so much.
Thank you.
I'm not seeing any more hands. Um,
I wonder, Andre, if I could ask you a question in that case.
Let's go first too.
A question I preempted was, so I'll ask it. What do you think about resource implications? Does this kind of thing fill you with another ask, something else to resource? And if so, I wonder if we could think about how that might be resolved.
So, you know, when we started the project, part of that went through my head because I thought I could just imagine the notes coming back and saying, well, if we have these findings, we need to do something about it. And I think that it becomes increasingly difficult because when you mentioned earlier on about the greater awareness around mental health, what it also sparked is that increasingly there's an awareness about mental health, but in low middle resource contexts, that often becomes even more difficult to do something pragmatic about it. And I think that one of the ways of thinking and addressing it is how do we integrate it into the wellness of the node, for example, that we maybe need to think and re-look at that we're not just producing field workers that are part of a sausage factory and are going out and collecting data, but that we need to think about what are we're very concerned about the physical well-being, the security of the work, field workers, etc. But that built into that, there also needs to be an address around social and mental well-being. And I think that there's so I have a colleague who works in the mental health space, but more specifically around like how to take address this at the population or a community level, considering the resource constraints. And I know there's some interesting work that have been done, for example, like with the community benches and that strategy which is used in places like, I think it was Zimbabwe that it was first initiated. But maybe it's looking and adapting some of those low-cost strategies for the context that we work in, and to bring some of those community-driven strategies that can help address it. And I think also what we sometimes forget about is that, and for lack of a better word, is thinking about indigenous knowledge systems that can help address this. It's like, what are the cultural norms that exist within that community, and what is the strategies that have been used, for decades, for even maybe centuries, in terms of how to deal with mental well-being. Because the issue of mental well-being, I don't think is necessarily a new issue. It's like it may be an issue that is taking on a different guise at the moment, and it may be intensified because of the social constructs that we operate within at the moment. But even before that, there were these mental health challenges that existed within communities, but there were ways of dealing with that. And is it about looking at whether it is in a rural setting, it might be a more, that at a tribal level or a clan level, that there are strategies that are put in place for dealing with mental health issues, and how do we tap into that construct of dealing with it. And then maybe in an urban context where that norms have shifted, is what are some of the ways that people are coping with mental health challenges? It might be that they are utilizing faith-based organizations or structures, so is there a way of doing that? And I think that for us, certainly in the nodes, is that that's something that we have to think about. It's like, what are the existing frameworks that may be in those communities that are not being fully utilized to help tap into dealing with some of those issues?
That's so interesting. And some of those are common to the coping mechanisms that were reported by implementers themselves in the
Yeah.
family through prayer and so on. When I was thinking about the resourcing, I often get a bit frustrated with health economists for sometimes I think having a narrow view of costs and benefits. And I started thinking about A, low cost, no cost. A lot of this stuff is done anyway.
Mm.
Is this a question of kind of systematizing and formalizing this? And B, what about the costs of inaction that we always conveniently don't seem to have in our analytical frame? And in, I guess, this context, it's things around attrition, absenteeism, data quality risk, and in our data, actually a hospitalization. So, with a slightly wider lens, I guess you could argue that there's more of a benefit than a cost of organizing existing practices, as you're saying, utilizing existing knowledge structures into something hopefully encompassing.
Mm. Yeah. I think we have time to squeeze in one more question if there is. Else, I will close off the meeting. Don't see any hands. Lucia, thank you very much. I don't know if you have any last words that you want to share, or
Um, just really acknowledgements and thanks, and personally to yourself, Andre. Thank you for tolerating a social scientist for so long in an otherwise quite quantitative space. It's just an honor for me to work with and for the network. So thank you.
no, thank you. Thanks everybody for attending, and we look forward to seeing you on the next SAPRIN webinar. And Lucia has now got to go to make intercession for Scotland, who will be facing Brazil later. And so we wish Scotland all the best for that, Lucia.
Thank you. I appreciate that greatly.
Thanks. Thanks,
All right.
everyone. Cheers. Bye-bye.
Thank you. Bye-bye.
Thanks, Lucia. That was really excellent. Really appreciate it.
Of course. Thank you.